The system designed to protect your community's health is the same system profiting from its decline. And until you stop waiting for someone in a boardroom in a city that's never heard of your neighborhood to hand you a solution, nothing will change. Public health doesn't see your neighbors, it sees data points. It doesn't treat your community, it manages it. And every year it stays in charge, the gap between the people making decisions and the people living with the consequences grows wider. Today, we're talking about why public health fails and what it means to you if your community doesn't take it back. Here's the bottom line. The government actually doesn't give a shit, and in 2026, they're making it official about your community health. The current administration is actively dismantling the infrastructure we use to keep communities like yours alive, and they're calling it merit. I'm calling it dangerous. I'm a community family medicine doctor. I grew up in Long Beach, under-resourced neighborhood, Pacific Islander family, and I've watched up close how public health talks about communities like mine while doing almost nothing for them. Today, I'm showing you exactly why, with receipts, with science, and with some real talk about what's happening right now that is making all of this significantly worse. Because once you understand why the system keeps failing, you'll finally know how to stop letting it fail you. Here's something most people don't know. Public health in America isn't one unified system with a plan, it's a patchwork. Thousands of state and local health departments, loosely guided by federal agencies like the CDC and HHS, all operating differently, different priorities, different funding, different rules. No quarterback, no unified game plan, just patches. And when a crisis hits a community like Long Beach or the south side of Chicago or rural Appalachia, those patches don't hold. And here's what's wild. The US spends more on healthcare per person than any other developed nation. And we have some of the worst outcomes, worse life expectancy, worse maternal mortality, worse chronic disease rates, more money, worse results. That's not bad luck, that is architecture. And right now, that architecture is being deliberately weakened. I'm going to show you 5 reasons this patchwork keeps failing and exactly how today's political climate is accelerating every single one. Let me describe how public health typically operates. Experts, brilliant people genuinely sit in offices in DC and write guidelines. They create mandates, they publish recommendations. Then those get handed down to communities like, here, follow this. No context, no conversation, no explanation of why. You're working 2 jobs, commuting 2 hours, 2-year-old at home, and public health shows up like, have you ever considered a Mediterranean diet? That's not healthcare, that's a TED Talk nobody asked for. A 2022 study in Plus One confirmed it. When communities feel preached at instead of partnered with, trust evaporates instantly. Now here's where it gets real in 2026. The current administration's push to eliminate DEI training in medical schools and hospitals is making this worse. Future doctors are being trained without learning about structural biases, social determinants of health, or how a community's context shapes their biology. That means the next generation of physicians will be more likely to see a non-compliant patient instead of a patient living in a food desert with no car, no time, and no safe place to exercise. The fix isn't complicated, it's just humility. Stop talking at people, start talking with them. Here's one of the most powerful and most ignored truths in medicine. Your zip code predicts your health more than your DNA. Life expectancy varies 10 to 20 years between neighbors just miles apart. Not because of genetics, not because of willpower, because of environment. The science on social determinants of health is ironclad. A 2016 study in Health Affairs confirmed it. Housing, food access, income, and neighborhood safety are the primary drivers of chronic diseases. So what does public health do with that information? Tells you to eat more vegetables. It's hard to follow a low-sodium diet when the only affordable food near you is ultra-processed. It's hard to take a 10-minute walk when you're commuting 2 hours each way. That's not laziness, that's time poverty, documented, real. Now here's the 2026 gut punch. The 2026 executive order targeting DEI is actively discouraging providers and clinicians from examining desperate orders based on race or community context. When doctors are politically pressured to believe that noticing a patient's zip code or racial background is somehow discriminatory, they stop looking. And when they stop looking, they miss the early whispers of disease. The slightly elevated blood pressure in a 32-year-old black man the early kidney damage in someone with chronic stress exposure, the conditions that are completely treatable at stage 1 but catastrophic at stage 4. That's not merit, that's malpractice. This one hits different for me as a Pacific Islander. I've seen brilliant health campaigns designed for someone else entirely. If messaging isn't the primary language of the community, if it doesn't respect cultural foods, family structure, or lived experience, it gets ignored. Period. The consequences are deadly. Colorectal cancer rates in younger adults are rising. It's one of the most preventable cancers we have. But if outreach doesn't reach Black and Latino communities in a way that resonates with their specific fears and realities, those patients keep presenting at stage 3, stage 4, it's already late. A 2023 AHA scientific study confirmed programs that actually worked in underserved communities did one thing differently. They used trusted messengers from within the community, not outsiders with clipboards, community members, barbershop conversations, church announcements, people who already have credibility and trust. And now in 2026, the FDA has withdrawn its guidance requiring diversity in clinical trials. That means the drugs being approved, the treatments being tested, the dosages being recommended, they're increasingly being validated on populations that don't represent yours. That's not a detail, that's everything. This one makes me generally frustrated because it plays out in exam rooms every single day. Public health can recommend all the right early detection tests, ApoB levels, LP(a) screening, urine microalbumin for kidney function, and FIB4 for liver health. Tests that catch disease early when we can actually do something about it. But when insurance doesn't cover it, or your doctor's too rushed to order it, or the patient can't afford the co-payment, or the results come back and nobody follows up, that's clinical inertia, waiting for a dramatic symptom before acting, reacting instead of preventing. A 2025 study in BMC Public Health found that top barriers weren't bad science. 43% of practitioners cited inadequate funding. 42% cited shortage of skilled personnel. The science isn't the problem, the system is. Now connect this to 2026. The Medicaid work requirements in the 2025 legislation are already covering coverage for the most vulnerable patients. The people who most need early detection, gone from the system before the first test is even ordered. This is clinical inertia weaponized by policy. Let me be real, many communities, especially Black, Indigenous, Pacific Islander communities, have valid, documented, historical reasons to distrust the public health system. Tuskegee, forced sterilization, J. Marion Sims, the maternal mortality crisis happening right now where Black women die in childbirth at 3 to 4 times the rate of white women in the richest country in the world. That's not conspiracy, that's the record. And what does public health typically do? Shows up to give a vaccine or issues a mandate, then disappears when the community needs mental health support, affordable housing, and safe streets. The relationship stays broken because the commitment was never consistent. Community health programs, minority health initiatives, diversity pipelines in medicine, all targeted. When governments eliminated programs that said, "We see you, we're coming to you, we're building care around your reality," and replaces them with silence, it doesn't just fail communities. It confirms what communities already feared. The system was never really for them. A 2024 study in the Journal of American Public Health found that dismissive, condescending public health messaging actively increased distrust in already skeptical communities. Now imagine what policy does. You can have the best science in the world. If people don't trust the hand holding it, they won't take it. So what actually works? 1. Invest upstream. Housing, food access, safety, education. These aren't social issues separate from health. They are health interventions. Full stop. 2. Design with communities, not for them. Real co-design, real power sharing, community advisory boards that actually have authority. 3. Remove the gatekeeping. I gave you the actual names of the tests so you can walk into your doctor's office and advocate for yourself. That's why this channel exists. 4. Rebuild trust through consistency. Show up when it's not a crisis, stay when it's inconvenient. 5. When the federal system tells doctors not to see your race, your zip code, or your community history, find a doctor that does. The government built a patchwork and is now quietly pulling threads. So we build a bridge they won't. That is what this channel is. That is what a community doc does. Listen, this isn't about left or right. This is about science. This is about your family. I became a doctor because I came from the community that kept getting left behind. And if the system won't fix it, we become the fix together. If you enjoyed this video and want to see more, watch this next video on the 5 silent killers. I'll see you in the next one. Peace.